So, good morning. I'm Francesco Bedogni, the head of adult cardiology in the San Donato Hospital. With me is Federico Coldemarco as chief of the structural heart disease in our institute. Mauro Agnifili will present the case. It's a great honor for me to have in a cath lab Mark Carlos Ruiz. It's the history of structural heart disease in the world, so it's a great pleasure for us to have you, man.
Thank you for having me.
So we will present the case of TAVI, of transcatheter valve, aortic valve implantation. I will show the case. Mauro Agnifili, will you present the case now?
Yes. So we are talking about a patient of 82 years old, smoker, hypertension, dyslipidemia. In 2010 she had a colon cancer treated with right hemicolectomy. In 2016 he underwent of implantation of a dual chamber pacemaker, permanent atrial fibrillation. He has a moderate to severe aortic stenoinsufficiency with a slight depressed ejection fraction 45. In 2017 he had a worsening of dyspnea, and this is why he was hospitalized. The STS, as you can see, is not that high, 1.7, and after the heart team discussion we decide to treat this patient with TAVI. The echo pre-procedure show a small ventricle with hypomobile aortic valve. As you can see on the right side of the slide, the aortic regurgitation is moderate. And this is the aortic stenosis. The mean gradient is 40, the peak is 66 with 0.6 area. This is regarding the mitral regurgitation, moderate. The coronary angiogram show normal LID, circumflex, and the right coronary artery, so nothing interesting regarding the artery, the coronary arteries. And the CT scan find an annulus of 80 of perimeter and an area derived diameter of 25. As you can see, we don't have a big calcification. The calcium score is quite low, but what is more interesting is the angle of the aorta. It's 70, so quite a horizontal aorta regarding the implantation angle. The femoral axis, iliac femoral axis are good. We don't have a big calcification of the iliac arteries, so it's quite a nice axis. So the crucial points in this patient is an horizontal aorta, 70 degrees is the implantation angle, low calcification score. So we decide to choose for oversizing, valve oversizing. The iliac axis are good, and this is the valve that we are going to implant, cymetis, regarding the stability, the very good stability of the valve, especially nice for the horizontal aorta, and due to the stabilization arches and the optimal alignment of the valve.
Yes, very nice presentation. You can hear us okay? Is that correct?
Yeah, absolutely perfect. If you can see the pressure now, you can show the pressure. There is a mild to moderate aortic regurgitation, not so big, but anyway, there is a big gradient to the hemodynamics, so we decided to pretty late. Federico will show you what we did until now, so you can show.
Can I ask you a question before you get started? A lot of the members of the audience are not participants in TAVR. And so, one, this would be considered a low risk. It's a 1.7 STS score. So that would be in the low risk protocol in the United States. Do you have something similar to that in Italy? And then also explaining how the accurate implant works, because it's much different than the core valve or the sapien valve, the implant. But it's a relatively low risk, the STS score.
Yeah, we discussed with a surgeon about this, and we discussed with Carlos Ruiz before for this implantation. He's a low-risk patient, but he's a 82 years old patient, and I think as more than 80 years old patient, we have to be considered the possibility to perform a TAV in a patient. The patient was sent by a very new cardiology, very expert cardiology that started with TAVI and asked and discussed before with the patient. We consider the age of the patient, the referral choice, and the patient choice, and this is we consider no so many risks for TAVI. So we discuss a lot with the surgeon. At the end, the final decision of our team was for TAVI. What do you think, Carlos, about that?
I agree. I mean, this is not, again, within the standards of the FDA approval for TAVIs, but the main reasons why we do not do lower risk patients is primarily because, first of all, we don't know the durability of this valve. In this patient, he's 82 years of age, had colon CA, and I think it's a very reasonable clinical judgment to put a TAVR if that's what the preference of the patient is.
Yeah, no, Carlos,
Yes,
I agree.
In our institution, sorry, just to say that in our institution, the mean STS score risk is 6. So this is a sure it's a low risk patient even for our institute, but we consider that it might be a good option for this patient, especially for 82 years.
We are currently doing in trials right now in the U.S. for low risk patients.
Yes.
So the intermediate risk, so STS over and above 4, have already been approved. Now we are working on doing a low-grade patients, and I think this is a very reasonable patient that as a clinicians we should encourage to do, if the surgeons agree with it.
Yeah, Carlos, that was my point. Just as you know in the States what our FDA regulations are right now, and we are in the low risk. This patient would still qualify, just like you said, that the adjusted was 6, and so I think that again, just for everyone in the audience that's not so involved with the TAVR procedure, just to kind of understand how the judgment goes about whether they go to surgery or to TAVR. Obviously, this is an excellent patient for this particular procedure.
Right.
And depending on the prosthesis choice, what do you think, Federico?
So I agree with what has been said. I mean, for horizontal aortas, definitely it's useful to choose devices which are stable during the implant phase. So, good choices for this kind of anatomies could be either a Sapien 3 or a Symetis. They both behave well with horizontal aorta, whereas
Hey, Carlos, can you ask your IT crew to fix his microphone? We can't really hear him through his mic. I know he's talking about the choice of valves, but the mic's not working. Can you ask your crew to fix that, please?
Yes, certainly. They are addressing that, but I can repeat, if you didn't hear what you said, that basically in a horizontal aorta, the ideal choice is valves that do not really depend very much on that angulation, i.e. the Symetis is a great valve for that, and also the Sapien 3 would be an acceptable choice for this patient. You would try to stay away from the portico or from the core valve prosthesis. So I think this is a very good choice, and I'll tell you, this is very exciting for me because, as you know, we don't have the Symetis in the U.S., and it's a great chance for me to learn from them how the Symetis is being deployed. It's really a great opportunity for me, so I'm very privileged.
Okay.
Okay, we can show you where we are at. Can you hear me now?
No. We just barely, the mic's not.
We have to fix the problem, microphone problem anyway.
Yeah.
I will show you. You're probably to fix now the microphone problem.
I'll help you.
Okay. So we all the time we protect the control by the contralateral access the puncture side of the large sheet. So we do crossover. We pick the left femoral artery. We do crossover. We put a 0.18 wire in femoral artery. Okay, you can. We will see it's very perfect. A very large vessel to be punctured. Then go ahead. Then we do the puncture under fluoroscopy. Okay, it's normal. We prefer every time, even if the sheet are lower than in the past, the lower profile than in the past. We prefer any way to avoid any kind of vascular complication. So we protect all the time, or from a contralateral section, or from superficial femoral artery, the puncture site. So now we put a large sheet, 18 French Boston sheets. It's a very nice sheet. This is the first injection. As you will see, we are in the left coronary sinus. So we prefer to do the injection in a preferred position to try to be absolutely horizontal and in a perfect position for the implant. So the next injection is a non-coronary sinus. Is a quite good projection for implant. You can see there's some calcium, not so much, but there's some calcium, and the gradient is absolutely high. So we decided now we cross the valve. You will see with an Amplatz AR1 cut. Okay, we could cross the valve. Okay, we cross the valve and we enter with the Amplatz diagnostic catheter. Perfect. Then we retrieve it. We place a pigtail to avoid any kind of perforation by the wire, and to be sure to place in an apex our stiff wire. Okay, and then we are at that point. We are ready to start the procedure. We decided to pre-delay it because this is a valve, a very good valve, a very stable valve, but with mean radial force. So we decided to pre-delay due to the large gradient the valve, and so we place a pre-shaped wire, a safari wire. If you want to show them this the wire in the middle. If we can have the window for the procedure. Anyway, we'll see it in a ventricle. So we proceed to put the stiff wire in the ventricle.
While you're putting the wire in, can you explain, because I know it's a low calcium score and you were talking about oversizing the valve. I thought the perimeter was around 80. So what size valve are you talking about being an oversized valve for the accurate?
Okay, if you can hear me now.
Yes.
I will explain you, okay, size choice. So basically, if you consider perimeter-derived diameter, that's what we basically focus on when we choose the Symetis device. It's quite a simple sizing scheme because it exists in 3 different sizes: the small, the medium, and the large device. And they are able to treat diameters in 2 millimeter steps. So the small size can be used up to a perimeter-derived diameter of 23 millimeter, the medium up to a perimeter-derived diameter of 25 millimeters, and the large treats basically annually from 25 to 27
Torna sulla proiezione del
millimeters. So since perimeter derived diameter in this case is 25.7, perimeter of nearly 81 millimeters, it's basically in the mid-range for a Symetis large size. I mean, the calcium is, I would say it's moderate. It's not light in this case. So it's probably a good choice.
What do you think, Carlos, about the predilatation in this case?
You know, the predilatation, it depends on what prosthesis I put. When I put the Sapien 3, I am less anxious to predilate the valve. On the other hand, if I put the portico valve, I'm more inclined to predilate more aggressively to avoid any post-implant dilatation.
Okay, so in this case, due to the valve and due to the gradient, we decide to predilate the valve. So we are ready. We do rapid pacing through the wire because the patient has a permanent pacemaker. So we consider to not put a pacemaker through the vein. So we do the pacemaker, the heart strip full through the wire. Okay. Pacemaker on.
And what size balloon did you choose?
23 balloon.
Okay.
For an average diameter annulus of 25, so a little bit undersized, but we think anyway you have seen that the valve is quite large, but anyway I think we achieve our results. What do you think?
Looks very good.
To predilate with another balloon?
I wouldn't.
No.
I think if it's comfortable, again, I'm not familiar with the use of the Symetis, so you have the experience, and if you think that this is enough with one balloon,
Yeah, I think, I mean, we can post-dilate the device in case it's needed. You know, with what's your post-dilatation rate with the self-expanding devices? I tend to be very liberal in post-dilatation with self-expanding devices.
I basically grade that depending if I have a paravalvular leak or not. If I don't have a paravalvular leak, even if it doesn't look fully expanded, I stay away from ballooning. On the other hand, if I have a paravalvular leak, that's my first choice, to balloon expand the valve.
Okay, this is the device. So you're going to see during the implantation, there are two different steps of implantation. One, which is the first portion of the valve which expands, is the one on top of the annulus, and then secondary, you expand also the bottom portion of the device. You're going to see this in a second.
Could we, during the implant, could we have fluoro and picture-in-a-picture of your hand so we can understand how the accurate works?
Can we have the windows for our hand and the main picture and the screen?
Yeah, perfect.
Thank you so much. So the valve is in the descending aorta. She navigates very easily. Mettiamoci sull'arco. We try to avoid, it crosses very easily the aortic arch. Now we are in ascending aorta in front of the valve here. We can pull back a little bit on the wire to facilitate to cross the valve, you know.
Okay, so the first marker which is important to position, it's that little wider part in the bottom of the valve. You see that there is a very radiopaque marker which is below the annulus level at this moment.
Yes.
And that's So that's a thick metal part. And if you look proximally to that, you see a slightly a slight enlargement of the valve, which is the first juncture of the nitinol cells of the bottom part of the valve. And you see that Dr. Bedogni is positioning that portion exactly at the bottom level of the pigtail, which is the nadir of our virtual basal ring. So the ideal target would be to place the device with that first nitinol frame junction at the level of the virtual basal ring.
Yeah, I must tell you, we watched Alex Abazid do the first in man in Sao Paulo, and when I didn't understand, like Carlos was saying, I didn't understand the device, and I thought he was putting it in the wrong place. I didn't understand how this device opens up. It's much different than any of the other devices.
Absolutely, yeah. The difference is that it opens, you know, with the top part first. So that's the main difference. Okay, I think we are basically at the place. We can take another root shot to just verify that we are okay. Looks like we are okay, so we can start opening the device very slowly. You know, and what I do is to turn this portion very gently, very slowly. Basically, there should be no movements to the catheter at this phase. You see, we have opened the upper crown first, which is that portion of the valve that opens just on top of the pigtail.
Just a moment. Okay, to check again, probably I have to push a little bit more.
But very gently.
Is there a time during your deployment that you do rapid pacing with this device, or no?
No. Not really anymore.
Okay.
Not really anymore. That's what we did maybe in the first phase of our implantation. I think we can take another quick root shot to verify our position. We have some kind of low pressure, so we might not want to wait too much. Maybe we could gently push, gently. Okay, that's enough, I think. I will go on very slow opening of the device. And now we will open the stabilizing arches that you see on top. It's important to go very gentle and very slow in this phase. Now I feel a hard stop here. We take another root shot. The device looks pretty okay. So I think I will just push very gently on the wire and remove this safety pin here, and then open quickly the bottom part. And you see how very stable and predictable device opening is.
Okay, we can pull back now the...
I remove some tension of the wire, then we very gently pull away the delivery system. If we could change magnification. Okay, very good.
So a couple of questions. One, you left the pigtail in, and that's fine with this device because it's easy to get out. That's number one. And then the second is, it looked like you're stabilizing. You know, the ascending aorta is really large. So unlike the core valve or the Evolute R, it's not really. Is it against the wall, the ascending aortic wall, to stabilize, or it's just the length that's stabilizing the device?
So it's okay to leave the pigtail there. Okay. That's what we generally do. Leaving it there maybe in very narrow and very small anatomies to possible risk, you know, of entrapment. But definitely with large anatomies, there is no big issue in leaving it there. And yeah, the device stabilizes both to obviously the interaction of the bottom part of the device with the annular calcification and the leaflet calcification, and also the stabilizing arches up in the ascending aorta provide orientation and stabilization of the device.
We leave, every time we leave the pigtail there because it gives us the possibility until the end of the deployment to have, we would do this with every kind of valve to have until the end the possibility to check our position.
Is there a time in your time in your deployment where there still is retrievability, and where is it where it's during the delivery, it's a go or no go. I mean, for this particular device, is there a time when you still have repositionability, or can you explain that?
This is a very good question. So you have basically can reposition the device up to the full opening of the upper crown and of the stabilizing arches, meaning that you can pull it up or push it down. What's important with this device is to have some the final movement before opening the device should be a pushing one towards the ventricle. Since it opens with its higher portion first, it's important to have that pushing tension in order to have an accurate opening and a stabilization of the device in the anatomy.
What do you think, Carlos, about this device that you don't know?
I've seen it many times. This is the first time that I'm really seeing it in front of my eyes, not on the screen. It's lovely.
No, it's not difficult anyway.
No,
we are only to push.
You made it look very, very simple.
Can you show us the hemodynamic, because you're getting ready to do LVA, ascending aorta. Can you show us the pressures?
We have to do 0 before. Okay, we facciamo 0. Okay. So anyway, we will check now the result, the hemodynamic result, the angiographic result, to decide what to do, if post-dilate or not.
Yeah, can we see your hemodynamic tracings, please?
Hemodynamic, not perfect. Yes, it seems to be a gradient,
which is strange.
This
it's one of the first
times
we can swap over the lines.
Switch, because sometimes with the pressure we have some pressure, as everywhere, I think, because some not everywhere. I saw there are some problem with the pressure, but if it confirms,
so
this is
it's a transducer.
Transducer problem.
Yeah.
So we will change. We try to do the 0 again, and we try to flash again the pressure before to inject.
Which is somehow reassuring to see a transducer issue and not a real gradient.
Yeah, and do you do any?
There you go.
Yeah, that's still. Yeah.
Lava meglio questa.
You have a bubble in one of the transducers.
We flash again. Yeah. Now this is important. We are from the beginning. We are very. We treat very careful for the pressure, because it's very important to know how the patient will accept in an aortic regurgitation. So the hemodynamic is absolutely important.
Now you do.
It seems better, but we have an increase of diastolic.
Another thing is to do maybe a root shot now, but without taking away our LV access, because if you want to post-dilate this device, then one of the potential complications that you definitely want to avoid is to cross the stabilizing arches and inflate a balloon through the device, because you might have an issue in taking it away. So we can leave the picture there for a moment. We
can change the projection just to see if the device is compressed in other projection.
Do you calculate any of the diastolic indices to try to determine beforehand about aortic regurg, either perivalve or aortic regurg, or do you use any of the measurements, your EDP and your mean pressures, etc., and diastolic aortic? Do you calculate those?
Yes, we consider a lot seen in index.
There is a nice diastolic notch
but
on the aortic.
Probably now the difference between between the diastolic and diastolic pressure and the diastolic pressure. We consider a lot, and you have to know anyway that it's dependent on heart rate. Even if there heart rate, and this is very important to consider.
I think we can take, the device doesn't look compressed in the contralateral view. I think we can take a root shot in the coplanar view and then take the pigtail out maybe.
Okay.
Okay, so let's just...
Sometimes the pigtail can... the other one. This is, anyway, we could see that
LV is a good function.
Good LV function.
Yeah, the LV looks good. Now, what about the aorta?
We changed before the transducer, and
Yeah.
so anyway, it's okay. I will change anyway. Good left ventricular function. Okay. Okay, ready to go?
So we
There are
have some aortic regurgitation. I would consider post-dilating the device in this.
Absolutely.
So you're
because
very
the-
liberal on
I'm very liberal. I think, yeah, well,
so for that you would use the same 23 or you would go to a 25?
I would go to a 25.
25.
Probably, yeah, okay. Well, let's go. I don't think that with 25 we could do too much. I would like to post-dilate with 28, but anyway, I listen and I start with 25 and then.
And then if you need, you go to a 28.
So the decision is to post-dilate to optimize the result, okay?
The LV and
Anyway,
So do you use any kind of image? Is the patient awake? Is that correct? So you're not using TE or anything, correct?
we try to avoid the transesophageal echo. Eventually, we have the echo in the cath lab, so the transthoracic echo we can, if we need more information, we try to do it with the transthoracic echo. We try
Okay.
to avoid. The patient is very well. Is absolutely. We have no problem, so we try to avoid general anesthesia in this patient. What do you think about that?
We do the same. We try to avoid general anesthesia, and we are very liberal on using the transthoracic echo. And in doubts, I'd rather put an ICE catheter and explore the aortic prosthesis with the ICE catheter.
What do you think about this regurg? Because the position of the valve is correct. So
I have no experience. I see the amount of AI, but I could not tell you whether this is paravalvular or is because the pigtail was there.
That's
Yeah.
another possible explanation.
can you
but,
see
you
again?
know,
Ci puoi dimostrare? Can you see again the angio after the implantation? Facciamo più alto il.
I mean, if it was a stiff wire through the valve, I would say that might increase a lot AR, but maybe a pigtail, not so much.
Yeah.
So
So yeah. Now, there's with this valve anyway, we have to be very careful with the post-dilatation because probably there is some cases of damage of the leaflet after an aggressive post-dilatation. So I think at the end it's not a core valve, so probably pacing on. I think is a 25 conservative approach is
okay.
doable. We are pacing with the wire, but not always it works.
Okay, spacing on.
Se fai tu vicino,
Sì, sì.
vai al massimo 20.
Okay, we have some minor issue with pacing here. Okay, vai.
20 di uscita. Through the wire we can't now do pacing, but eventually we have
Let's try to reposition this.
another solution to put a balloon tip pacemaker from the van that we have, so no
Okay.
trouble.
Pacing on.
It works.
Abbassa la frequenza. 150. Ok.
So se basta.
Sì, dai.
Vai.
Stop.
We did something, yeah. Stop pacing, okay. What do you think? We do another one or we still,
No, I think we are okay. I mean, let's
Okay.
look. Let's have a look at that again. Can you play that again, please?
Okay. Let's check the post-dilatation. With not aggressive post-dilatation, so I think anyway we move. Yes, we could expand a little bit the valve. What do you think?
I don't know if the 25 will do it, but just referring to what you were talking earlier, to consider probably, if I still have AI, go with a 28.
Yeah, probably the 28 is very aggressive.
So what
people from Symetis
people recommend is to avoid overstretching the
Symetis.
Yeah,
Anyway,
because you see where
I'll put
the
the
little
picture.
tabs close to the stabilizing arches is where the top part of the device leaflets are stitched, and they want to avoid overstretching
To damage the...
Yeah, to avoid kind of pulling it over the nominal diameter of the valve, which is 27. So with a 28 millimeter balloon, we would definitely overstretch that up to 28. And there is some concern that this could somehow damage the leaflet. So if we have an improvement in AI, I think we might be happy with that. What we are doing is to replace, a soft catheter across the valve, not to induce AI with a stiff Safari wire. Yeah.
Give us the flash both.
So we're going to watch your next angiogram, and then we're going to cut away and go to our speakers.
Yeah.
Yeah.
Okay, let's do the angio first. I think it's...
We are not inside, so
Okay,
let's do the angio. Okay, without pigtail, eventually we can come back to measure the pressure.
Let's
20.
Right.
Oh, sorry. Okay. We are still,
Still has some...
we are discussing. We measure the pressure then with the side.
It's underneath the left coronary,
Yeah.
if you look at it. It's a paravalvular leak.
Paravalvular, yeah, where the calcification on the
Right.
bottom of the leaflet
That's correct.
was.
We can, probably we will increase the size of our balloon.
If you want to change room while we work on
We're
this,
checking the echo to decide what to do at the end.
So guys,
Have you use...
we're going to cut away from you all because I know you're going to try to make a decision what to do next, and we'll go to our speakers, and then we'll come back to see the final result. Okay?
Okay.
Very nice. This is very nice. Thank you very much.
Thank you, Peter. Back to us.
Okay, you're back, guys. We can see and hear you.
okay. What we did is to reassess the AR with echo, and it appeared like there was, as you've seen on angio, that confirmed the AR, which was a little bit too much than what we like to have. So what we did, this is what we left you with, this kind of AI. So we reevaluated our previous inflation, which was probably not perfect with a 25 millimeter balloon. So we crossed over again, we crossed into the valve into the device. We verified not to be in the stent struts by contralateral fluoroscopy, and then we inflated again the same 25 millimeter balloon, but at a higher volume. So this can somehow reduced the AI to what we deemed acceptable in this patient, which started with a full moderate degree of aortic regurgitation. We took away the stenosis, we left him with a grade 1 AI, and that's it's definitely paravalvular, exactly in the point where the left coronary sinus is, where we had that basal leaflet calcification. So we accepted this final result, and we went on to close the access.
Even because our diastolic pressure, aortic diastolic pressure, increased from 55 to 65. So we think that with this patient can tolerate very, very well this situation. What do you think, Carlos?
I mean, again, I don't have experience with the Symetis, but it makes sense if you're going to oversize that and you're risking damaging the leaflets of the valve. I think the bottom result is that it's not desirable to do that. And this small paravalvular leak, I would manage medically.
So at the end, we already closed the access with balloon protection, and we will finish the procedure even without vascular complication.
Very good.
Thank
Thank you for demonstrating the new the Symetis device, and you'll have to obviously let us know down the road how the perivalve leak does. But thanks again.